Hi, everyone. I am thrilled to be here with you today. I just shared my screen, so please let me know if there are any issues with that as we go along. But I'm really, really excited to share this brand new work with you about polycystic ovary syndrome and kind of the untold stories attached to that experience. Let's see. Before getting started, I wanted to offer a land acknowledgement. Land acknowledgements serve as a reminder for us to recognize those who were here before us in the space we occupy and land on which we inhabit. And ETSU is situated on territory taken away from Cherokee people. Cherokee once inhabited lands of East Tennessee, Western North Carolina, South Carolina, North Georgia, Northeast Alabama. Today, the Eastern Band of Cherokee people reside in Western North Carolina. And kind of personally, I know many of us feel connected to the mountains of Northeast Tennessee and Western North Carolina, including myself. And as a small way of honoring Indigenous people, I like to think of them when I look at those mountains or I'm in those mountains hiking. So I'd like to just take a moment and pay respect to elders past and present. Thanks. So I'm really looking forward to talking with you about this current direction of my research because it is brand new, and in many ways I feel like I'm in the right place at the right time, that kind of all of my paths, personally, training-wise, research-wise, have converged on this one topic now, and it's what I'm meant to be studying. So I've studied stigma and health for 2 decades, and just within the last 2 years kind of realized that, gosh, I really need to apply this work to PCOS. So to get us kind of on the same page about PCOS, some of us might know what it is, but some of us might not. I'm going to show you just a brief 3-minute video.
Welcome to my vagina. In here, I make the rules. Rule number 1.
In a contemporary society, where an individual's ideal self is heavily influenced by pop culture and media, it is easy to understand why some women define beauty as being slim and hairless. Society's definition of beauty is extremely problematic because this ideal prototype can only be achieved in a specific cohort of women who have the biological framework.
I was diagnosed with PCOS at 12. In the years to follow, I suffered from irregular periods, weight gain, and a lot of body hair. I have always tried to remain a relatively healthy lifestyle. However, I constantly struggle with my weight and have suffered from anxiety and depression in university. There are many biases women with PCOS face, and without a proper understanding of PCOS and its implications, there is a societal gap in sensitivity that cannot be easily bridged.
So, what is polycystic ovarian syndrome? PCOS is caused by an hormonal imbalance within the female body, which can lead to a variety of both internal and external symptoms. While the disorder is not completely understood, there is a general agreement among physicians that 2 of the following 3 symptoms must be present in order to diagnose PCOS. The first one is menstrual irregularity, which involves an irregular or absent period, which can lead to difficulty getting pregnant. Secondly, increased levels of testosterone, which is associated with the excess body hair, facial hair, and acne present among women with PCOS. Thirdly, polycystic ovaries, the abnormal presence of cysts in the ovaries which can increase risk for uterine cancer.
These symptoms can be accompanied by diabetes, obesity, and heart disease. Currently, there is no cure for PCOS, but you can manage the PCOS symptoms through different therapeutic methods. Normally, symptoms of PCOS will resolve themselves once a woman is nearing menopause.
Studies have suggested that PCOS may have a large genetic component, as reports demonstrate that PCOS is more prevalent within family clusters rather than the general population. Furthermore, in a study by Ligro et al., which investigated PCOS outcomes in 80 mothers, found that 22% of daughters tested positive for PCOS. Increased androgen levels, a hallmark symptom for PCOS, was not exclusive to daughters, but was also seen in sons of these 80 mothers. While this suggests a strong genetic predisposition for PCOS, a clear linkage of specific genes associated with this condition is unclear. Genes that are relevant for PCOS are also associated with other genetic disorders, and thus determining the degree to which these genes contribute to PCOS poses difficulty. Genetics or not, women come in all shapes and sizes. They each have their own unique characteristics. All women are beautiful, and for those with PCOS, you should not view this as a liability, but as an asset which defines your uniqueness. Be comfortable in your own skin. Be you. To get more information about the pathophysiology of PCOS, please be sure to check out Part 2 on the Demystifying Medicine channel. Thank you for watching.
All right, so to recap, PCOS is a genetic, hormonal, metabolic, reproductive disorder syndrome that affects, this says women, I'm saying people born female. It is the leading cause of female infertility. PCOS can lead to lifelong implications, complications, anxiety, depression, some cancers, type 2 diabetes, liver disease, and cardiovascular disease, but these are less well studied. And so when we think about PCOS, we tend to think of it as affecting 10% of women in reproductive years. Some people say a little less, some people say a little more, but again, reproductive years is kind of a misnomer because people experience it well beyond. So we just don't have the research to know what is the implication for people like my age and older. And let's see, lots of people might go undiagnosed. We're going to talk a little bit about the invisibility of PCOS and really the importance of studying it. So one of the big things that has emerged in my research is the challenge attached to invisibility. So lots of people in society just don't know what PCOS is. People may have PCOS and not realize it. Physicians don't even know largely what PCOS is. There's a lot of lack of education in that regard. In fact, the people that I interviewed that I'm going to tell you about today mentioned invisibility as like the hardest thing about PCOS, even beyond experiencing the symptoms of it. And this invisibility is a bit ironic just because of how visible some of the symptoms are. So as the video talked about, some symptoms include facial hair, body hair, kind of in that male pattern distribution. And the image here on the screen shows you an assessment tool that's used to look at what's called hirsutism, or that excess body hair, and kind of the range that can happen with female bodies and where that happens. So you get a sense of that hirsutism, which can be very visible. And then about half of the people with PCOS are overweight or obese. And so that obviously is very visible as well. In addition, you have things like infertility, insulin resistance, maybe hair pattern, male patterned hair loss on the scalp, things of that nature. So kind of ranges with some invisible symptoms, but lots of visible symptoms. But PCOS has really over the years been considered just a reproductive issue because of its name, right? Polycystic ovary syndrome. And in fact, you actually don't need cysts on your ovaries to get a diagnosis. So that seems, the name may not be the best because it's not really implying the whole condition. PCOS really impacts everything, all areas of life. We just don't have a lot of research on this topic, and that's why we're talking about it today. We do know in a recent estimate, actually just in September, this was published, that about $8 billion a year in the US is spent on PCOS treatment. Each year, $8 billion. And this doesn't include everything. This doesn't include things like treatments for mental health. There was just not the data to include. And so this is really an underestimate even. So the purpose of my study was to really uncover some of the untold stories or give voice to people's experiences that have not been out there in the published research. And so my study was called PCOS Story Study, and I interviewed 50 people who were diagnosed with PCOS. I recruited them through social media. About half of these identified as gender diverse. So they identified their gender as something other than woman, so non-binary, genderqueer, transgender. And just over half were racial or ethnic minorities. I will say that this was really important to me to try to capture people's experiences that represented a range of identities. And so in order to do that, I really needed to attend to my own identities and positionality in relation to this work. So I too have PCOS, and I was diagnosed about 30 years ago. But I also am white, I'm female, mostly cisgender woman. I kind of hang out at the boundaries of gender, I feel like. I'm overweight, lesbian, identified, educated, and with good healthcare. So I know a lot of these were going to come into play, right? And who I recruited for this study, and not intentionally. And in fact, why paying attention to it, I realized along the way, I was recruiting a lot of white people. I was recruiting a lot of queer people. And so I had to kind of take a step back and do some intentional recruitment of diverse individuals. And so I'm happy to report that we do have some racial ethnic diversity and gender diversity represented here in the interviews, which I'm really glad about. All right, just checking the chat, making sure there's nothing I need to know in the moment. All right, so I also had some geographic diversity. So I didn't want it to just be people in Northeast Tennessee, because that's where I'm located. And so all of the individual dots on this map represent a person that I interviewed. So we had quite a bit of variation geographically speaking. And finally, I wanted to clarify that we have more research on the medical aspects of PCOS, although we still need much more in that regard, but much less on social and psychological research. And as a social psychologist, that made my ears ring and realized that, gosh, I really need to be tending to this topic. And so my study focused on issues like the invisibility of PCOS, the social impact, kind of the personal impact, how does it affect the self, perceptions of gender, as well as healthcare experiences. And then I definitely wanted to try to capture some of the COVID context. But this is a lot of information from the interviews, but I just really want to hone in on some of the main points that I thought might be especially relevant for the WGSS folks. So what did I learn? One of the big takeaway messages for me is that PCOS is a stigmatizing condition. And it's not just a stigmatizing condition, but it's actually a condition, like one condition, but with multiple stigmas, because although PCOS is a diagnosis, there's not a lot of necessarily stigma attached to the diagnosis, but it's more about the stigma attached to things like infertility and weight and body hair and facial hair. So those symptoms of PCOS rather than the diagnosis itself. And when we think about stigma, I wanted to clarify that this image shows kind of the multiple levels at which stigma can function or manifest. So it's like all of those things out in the culture, right? Heterosexism and injustice and oppressions. And then you have the interpersonal level where you have kind of interpersonal unfair treatment and discrimination and disgust and those interpersonal level things. Finally, you have those internal ways that stigma can manifest, like internalizing those negative cultural messages and really feeling bad about the self, and having that shame and embarrassment. So that's really, I think, the really insidious part of stigma is that piece where it comes internalized. But we saw evidence of PCOS as stigmatizing related to these different symptoms at these different levels. So the way one feels about the self, kind of those interpersonal exchanges, and then in larger institutions like healthcare. And when we think about stigma and why these symptoms might be stigmatizing, obviously what comes up is people who are born female often have expectations attached to that identity that's placed on us. And so kind of broadly speaking, I know we have some variation, of course, for racial and ethnic variation, but broadly speaking, we have these expectations in our culture, right, to be thin and hairless and attractive and fertile. We have the motherhood mandate, of course. And then finally, kind of that cisgender assumption that everybody who's born female identifies as a woman, and that we just have this binary way of thinking about gender. And PCOS kind of violates those expectations, right? So lots of overweight and obesity attached to this condition, not everyone. We have hirsutism, that excess body hair. We have hair thinning on the scalp. We have infertility or miscarriage. And then although PCOS doesn't cause one to be gender diverse, when individuals who are gender diverse have PCOS, their condition seems to be even less visible and less paid attention to. So I wanted to give you some quotes. I'm going to read these verbatim. I apologize for that, but I think it helps to really take them in. So these are direct quotes from the people that I interviewed, and I've included here some examples of stigma attached to weight. So Kim, a 36-year-old Asian cisgender woman with PCOS, said, "I feel judged about choices like things I eat or being perceived as lazy, or particularly as a fat woman. You know, I worry about what that does for the bigger picture of employment. Fat women are highly discriminated against by employers. I wonder if I've had job opportunities that haven't worked out because of my size. I have a pretty clear memory of going to an interview and having one of the staff at the interview couldn't stop staring at my body. It just felt really uncomfortable, and it felt very much about my body size." This weight stigma also came in the form of pressure to conform. Some of this was direct pressure from friends and family. Dylan gave one really compelling description of their experience as a 29-year-old Latinx female genderqueer individual with PCOS. There's a secretive layer to my life. Like, I think I learned when I was in 4th grade, I would get chastised by my parents for wanting seconds when eating a meal, kind of taking more, which resulted in like waiting for everyone to go to bed and then raiding the refrigerator. And so there became this hidden layer of what people see me eat and what I devoured in private. In college, for example, I would go to fast food, eat really fast in my car, hide the trash before anyone saw. Part of me was hidden because of the social pressure to navigate food in a particular way and be seen as a quote unquote good fatty. There's a lot of health moralism, and I need to perform in a way that is a good fatty. I eat the healthy things, just demonstrate behaviors that people perceive as healthy. So we also saw weight stigma appearing in healthcare, and this is not new, it's just new to the PCOS literature. We know that this happens for overweight people. There's a lot of pressure in healthcare around weight. So Jenna, a 36-year-old white female cisgender woman with PCOS, said, "At my very last doctor's appointment I was telling my doctor I was struggling to lose weight. I was wondering if we could up my metformin," which is a drug given to people with PCOS. And he said he didn't really want to up the metformin right now, but maybe I could just control my diet better. I was like, well, I already restrict calories. There are some days when I don't eat more than 300 or 500 calories a day. And I know that's not healthy. He's like, well, that's okay. So you end up internalizing that. It's your fault. I need to eat less. I need to work out more. But no matter what you do, it doesn't change. So really the stigma surrounding weight and kind of almost recommending an eating disorder here. So it's really evidence of that bias about weight. We also saw stigma related to the body hair. So Sophia, a 46-year-old white female cisgender woman with PCOS, said, probably more so keeping private as far as trying to get rid of hair growth. That's not usually something I talk about. Different products, doing different things, getting rid of chin hairs that appear, and the stigma of that. I've seen with circuses, the bearded lady. It really bothers me, the circus stuff, the sideshows from years ago. It having the bearded lady in it. She's overweight and she's got hair growth, and you're thinking, okay, she's probably got PCOS. This also manifested in beliefs about gender and perceptions of womanhood. So Megan, a 20-year-old white female cisgender woman with PCOS, said, I feel like PCOS makes me feel much more masculine than I want. I mean, I feel feminine, I identify with feminine traits, I identify as female, but I feel like people will see these really masculine traits. I have prominent sideburns, which I'm getting removed by laser. It makes me feel like I look like a man, and I don't want to look like a man. I feel PCOS mainly makes me look very masculine. And there also was distress related to this, this gender perception or threatened womanhood that I'm calling a dysphoria related to gender. So for example, Farah, a 25-year-old Middle Eastern female non-binary individual with PCOS, said, most of my negative feelings about my body are symptoms of PCOS that I wish were different. I definitely have pretty negative views on my body and just a lot of shame around how I look. My weight, my facial hair, I have a lot of shame about that, embarrassment, just a lot of negative feelings. Mostly avoid talking about it, thinking about it, try not to examine myself too closely in a mirror. This was kind of echoed by Josie, a 19-year-old white female cisgender woman with PCOS, who bases her whole self-worth on what she looks like. I try and avoid mirrors or reflective surfaces at all costs. And if I pass one, I don't look at it. So stigma was definitely a strong theme, kind of at different levels. And then another thing that I learned is really focused around the importance of the diverse experiences that are mostly understudied or not studied at all with PCOS. And these were related to gender identity and racial ethnicity. One way that we can think about or kind of conceptualize these identities in relation to PCOS is thinking about intersectionality. And I wanted, if you were able to attend the recent Equity and Inclusion Conference, there was a speaker who I thought did a great job of clarifying the difference between intersections of identity. So, you know, we all hold multiple identities at once, with intersectionality, which is more about how those identities are linked to oppression in society. And so when you have multiple oppressions coming together, like those are related and those are going to explain your experience in unique ways and important ways. So thinking about someone with PCOS who also is a gender diverse individual or racially ethnic diverse individual, their experiences are going to be different and linked presumably to oppression like racism. This is just to give you an example of a recent publication had this visual that I found so helpful. It's called The House That Racism Built. And so it really helps you to understand how layered racism and oppression is in society, happening at a kind of broad cultural level in our institutions, as well as interpersonally, and then toward the self as well, and how that has multiple implications. And then when we think about gender diverse individuals, so not necessarily racism, but kind of the equivalent of that would be called minority stress. And so these are things, stressors and discrimination happening at the cultural level, interpersonal level, and self level as well. So thinking about PCOS stigma happening at those levels, and racial and gender identity related stigmas happening, kind of in the background or in the foreground, like all the ground, you can see how that can really compound or interact to influence experience of PCOS. One way that can manifest is something called intersectional invisibility. And I want to shout out to my student, Kelsey Braun, who introduced me to this idea. And it's really the idea that marginalized members of a subordinate group are exceptionally invisible because they're not the prototype for that subordinate group. So when you think about kind of the traditional way of thinking about gender, men and women are the subordinate group. And so they experience more stigma than men, who are the dominant. But then when you think about the marginalized within gender, so women of color, for example, or non-binary individuals, they encounter stigma and lack recognition of that stigma because of how invisible they are. So just thinking about that applied to PCOS, we basically have no published research on gender diverse experience and very little on racial and ethnic experience. So intersectional invisibility can help to explain that. Where this emerged in my study that I wanted to highlight is some variation around experience of the stigma, as well as stigma in healthcare. So this example is from Riley, a 23-year-old white Hispanic and Black Hispanic female non-binary individual with PCOS. Some of the characteristics that you get with PCOS are usually associated with male secondary sex characteristics. A lot of them used to make me feel really bad because I wasn't even allowed the choice to conform to the standards society placed on women. But now that I felt more neutral about it and have realized I'm non-binary, they don't bother me as much. I guess I moved from kind of shame about more traditionally masculine qualities to just viewing it neutrally. So this variation in the perception of these symptoms based on identity. Some people even saw PCOS symptoms as an asset for their diverse gender identity. I know this is a long one, but bear with me. I actually think it's a blessing ultimately for me. I had sort of a head start with some of the changes that have made me feel more comfortable in my body as far as testosterone goes. So I think for a lot of people, especially people who are women or identify as more feminine, want to look more feminine, this is a struggle for them because their bodies are betraying them with body hair and things they perceive as masculine. For me, it's been a blessing. I already had more facial hair than most people do on testosterone. I woke up kind of in the middle of being a few years into a low dose of transition just because my body was doing it. My body took to androgen very well. I've been on testosterone a little over a year, have a full beard. And a lot of these changes, trans masculine people really struggle to get and to achieve. And they just happened so fast for me because my body was tuned into it already. So really seeing that as an asset, some even said others were envious of their ability to grow hair so quickly. But on the flip side of kind of that positive perception, we also have this idea that the additional oppressed identities can cause problems in healthcare and additional stress. So, for example, Asia, 26-year-old African-American female cisgender woman, said doctors tend not to take African-American women's health seriously. So we know this. Like they always brush it off. It happens to me and it happens to other Black women. I just feel like that's something important because racism in healthcare is very obvious and it happens a lot. And then Tasha, a 27-year-old white female non-binary individual, said, most gynecologists are not super open to the idea of the fact that someone they're treating is not a woman. So I get treated like a woman. They don't believe me when I say I don't want to have children. It really is dysphoric and uncomfortable to be in a waiting room with beautiful, happy people expecting children. That makes me happy for them, but then getting treated like that is as my end goal is not, and not having non-binary, aspect of my identity respected and acknowledged. This is the final quote I'll share. The implication really is about treatment too. And so as we see variation in how we perceive symptoms based on gender identity, we see that our treatment options are not really living up to that variation. So Marsh, a 34-year-old Asian, white, Jewish, intersex, non-binary individual with PCOS, said, everyone assumes that you're a girl and you want to be normal, you want to be normalized. So gives an example of a doctor. He did a blood test. Your testosterone is high for a woman. I'm going to put you on spironolactone. I have a partner who's trans woman who's on that. Doesn't that make you pee a lot, have a lot of side effects, brain fog? What's the problem with testosterone? It gives me a high sex drive. It makes me feel good. Maybe it makes me grow some hair, but I don't have a problem with that. So why would I be on that prescription? And he was telling me that having high testosterone was a health problem and could cause me to have high blood pressure and heart attacks. And so I'm like, are you going to be on estrogen and testosterone blockers then? Because I feel like all men have that higher risk of heart disease. He just had no answers. He wrote down that I refused the medication. Later, Marsh comes out as non-binary. So I came out as non-binary, started taking testosterone. I went to a specialist. When I came back to the provider, he suddenly changed his tune and was like, okay, this is fine. It was like high testosterone was going to kill me, but now it's fine. So there's just all this pressure to normalize you and normalize your body. The things that your body is doing naturally are wrong and bad. More recently, he said he could take that off my chart because I'm a man now, which I'm not. I don't identify as a man. I also still have my ovaries. I've not had a hysterectomy. So he said that he could take it off my chart now because I'm on testosterone, which doesn't make any sense. Just because I'm on testosterone, he implied maybe I'm intersex and have PCOS because my dad is a nuclear physicist and was exposed to radiation, which also makes no sense. So really lots of things going on in this excerpt related to healthcare, lack of education, about that intersection of PCOS and diverse gender identity. Okay, so I spoke a lot about those excerpts surrounding stigma and then the diversity, highlighting how much more research we need. So for me, really my goal is to get more psychological researchers studying this topic, replacing silence and stigma with psychological research, centering the diverse experiences of gender and racially diverse folks. Of course, educating the public on what PCOS is, how it impacts all aspects of life and not just reproduction, trying to get more funding from the government to study this. Groups like PCOS Challenge, that's a national advocacy group trying to work with the NIH to get them to recognize PCOS as an important thing to fund. And then, of course, improving healthcare. There were so many examples of dissatisfied customers in the healthcare system, so much weight stigma, cultural incompetence. We really need to increase provider knowledge about PCOS, reduce weight bias. One thing I'll note about that in particular is the current guidelines that were developed in 2018 to treat PCOS. They actually list weight loss and exercise as like the go-to recommendations, which really we need to emphasize now that how stigmatizing people feel when that is the go-to without any explanation about why. And then increase cultural competence. Obviously, we need to work with providers to change the culture there. So special thanks to my research team in the Social Issues and Relations Lab, particularly Kelsey Braun and Sarah Jobe. I was funded for this project by the RDC on campus. And then, of course, individuals who shared so generously of their experiences with me in the interviews. So at this point, I would really love to open it up. We have plenty of time, I think, for, yes, good, for questions, for discussion. This is one of the very first times I'm talking about these data, and I really would love to know your reactions. Would love to know if you have any thoughts about what I'm presenting, suggestions for me, really anything. So would love to open it up now for that.
Thank you, Stacey. And just for everybody that is listening in, you have been listening, but now if you want to raise your hand to ask a question, whether you want to physically wave at us from the screen or raise your little Zoom hand, we invite you to come off mute and ask Stacey a question using your voice, or you can throw your questions in the chat box and we'll keep an eye on those as well. So thank you, Stacey. That was so interesting. I feel like I learned a lot, and I loved that idea that you raised about intersexual invisibility. I thought that was really powerful for thinking about, and also thinking about like why this hasn't even been studied before, right? Yeah. So anybody have questions for Stacey? Or just comments?
I know it can be really hard to like get the courage to ask the question, but I would really love to know what you're thinking, especially because this is such an understudied topic. Like, I'd love to know what you think about that.
McKenna said in the chat, I had never considered that PCOS could actually be beneficial to someone who's transitioning. That was very interesting.
Yeah. Thank you for that comment. Yeah, I actually, when I was early on in thinking about doing this project, I had approached my research lab students and it was like, this is what I want to study. And, you know, I have PCOS. It was the first time that I actually said that to people at work, I think. And it turned out that 4 of us in a room of 7 had PCOS. And it was absolutely amazing to me that, you know, we had worked for a couple of years together and none of us knew that about each other. And one was a trans man who described, you know, this challenge of like, do I treat my condition, my female body, or do I honor and respect my actual identity and, you know, not treat, which would, you know, feminize him. And so it was this real struggle, and gosh, it just really opened my eyes to the diversity of experience. Since that wasn't my experience, that was crucial to this project.
Benjamin, do you want to come off mute and ask your question?
Hello.
Hi.
Hey, I put it in the chat box as well, but I was just curious, you know, what are some of the treatment options? Is it, or do you just treat the symptoms, but like in particular case by case? And that does, you know, I think you mentioned not everyone wants to be treated.
Yeah. Well, there's a whole set of guidelines that have been internationally developed. So I talked mostly today about the US, but lots of research is going on in Australia, actually. It's probably the most heavily researched there. And so they led efforts for this international guideline for treatment. And it's definitely just treating symptoms at this point. So the birth control pill is a go-to treatment to regulate menstrual cycles, and the spironolactone is kind of a testosterone blocker, and that can be used for body hair and acne, things like that. There are evidence of testosterone, and then metformin, which is used to treat diabetes because there's such an insulin resistance component to PCOS. That's what kind of causes the menstrual issue with the ovaries. that can be a form of treatment too. But yeah, there's no cure because there's not enough research on what the actual cause is. We definitely are on that track with medical research, but we don't know. So yeah, it's not ideal. So one thing that has my attention, and feel free to jump in with your questions, but I just want to pick your brains really about the invisibility of PCOS. So I try to really emphasize that people often don't know when they have it because it's not talked about regularly, and the stigmatizing nature of the symptoms kind of usually cause people not to talk about it. And so why do you think that it's so invisible? What can we do about that?
I think one of the things you got at really well in your talk, Stacey, was the idea of like how it lines up with these sort of stigmas around like gender. And that really like leads people to maybe not want to disclose their diagnosis because it's already kind of a source of shame.
Yeah.
I think that's an interesting part of it, at least for me.
Yeah, for sure. I mean, I can even speak to my own experience in that way. Like I've gone most of my life without talking about it, and now suddenly I am, but why was that? I think someone else, Lucas, was it you that had a hand up?
Oh, Lucas, we can't hear you.
Oh, yeah. You still can't. Maybe use the chat if you can't get that to work. We want to hear from you. McKenna talked about, I love you are so passionate about open conversation and reducing stigma. I think education and conversation is so important. I obviously agree. And yeah, I've heard of that condition. There's no cure, little research. Exactly. I think people with PCOS also tend to have that as well. It's like some people talk about these other conditions that are somehow related, but there's not enough research. Personal anecdotes were incredibly moving. Thank you. Vulnerable, yeah. I know, right? Just to get that much harm from going to the doctor. And people did talk about not going to the doctor and how that is counterproductive for a chronic health condition. And so not only that, but actually research does pretty consistently show delayed diagnosis because of physician lack of knowledge. And so it can take people like 4 or 5 doctors before they get diagnosed. And if you think about someone who doesn't have good health insurance, like what about those folks? Are they even getting diagnosed because they're not in the system? So lots and lots of implications then for the condition worsening. And then when you think about the long-term impacts on things like heart health and diabetes, those are really scary conditions. And so if we're not being treated right, we're not being diagnosed, not everyone's in the healthcare system, like this is not a good scenario.
Kaylee, do you want to come off mute?
So it's kind of like a personal experience, I guess, because I guess it was either the last time or the time before I went to the OBGYN. They kind of briefly mentioned that I might have it, but he didn't really make it seem like it was a big deal. He just mostly because I have like a lot of irregular periods. Like I would go like 3 months without a period. and then I would have one and stuff like that. And I have a lot of acne, but I don't really have like weight gain or anything like that. Or I don't know if I have any cysts or anything. But like he just kind of made it seem like it wasn't that big of a deal. But then like listening to this, I'm like, maybe it should be a big deal. Like I don't know if I should like go and ask again, or if I'm going to get the same doctor that's going to tell me that it's not that big of a deal. Like I started thinking about it more. I'm like, should I go to the doctor? But I also don't know, because I think if you can only go annually, or else your insurance won't pay for it. So it's like, I don't even know what to do.
Thank you so much for disclosing that with us. I think your experience is common, unfortunately, that a lot of physicians think that PCOS only becomes a problem if you want to try to have a baby. In fact, my own experience just last year with a physician was like that. And I asked if they knew of any specialists who specialize in PCOS in our areas that I could reach out to. And my physician said, well, you don't want to get pregnant, do you? And I was like, no. And she's like, well, you don't have to, there's nothing else that you need to worry about. And I was so dismissive and so lacking in information. So I think it may not seem like there's an immediate problem, but given the long-term impact of PCOS, that it's really important that we get a diagnosis if we have it, and to get some form of treatment because things like high blood pressure and high cholesterol, those things are things you may not think about as much when you're younger, but they can kind of happen all of a sudden, and then you're on a track to worse health. So I don't mean to scare you or anything like that, but I just really believe in the importance of us educating physicians, and it sounds like yours is not educated, I'll just say.
It's weird that you mentioned the high cholesterol, because last time I went to the doctor, they even mentioned that I have high cholesterol.
Yeah.
So like, I've been really weary about that now too.
Yeah, so I think they oftentimes don't put all these things together, that, everything is treated so separately. And we really need to think of our bodies more holistically and how everything is related. So I don't have any specific physicians to recommend to you, but I know it's important to me. So as soon as I hear of one, I will kind of spread the word. But I would suggest, I don't normally give suggestions directly, but I would say, continue to advocate for yourself. And if you feel like something is wrong, if you might have this, then it's definitely worth fighting for that.
I would like to thank you, Stacey, for this so much, because I was diagnosed with PCOS 9 years ago, and now I'm 29, and I finally found a doctor after four doctors who specializes in PCOS. She's in Knoxville, but she's fantastic. And it took me, I'm 29. I've been having irregular periods since I was 12. It took me until I was 29 to find a doctor who explained why it was dangerous and the risk associated with irregular bleeding and not ovulating, and how that could lead to uterine cancer, and how there's so many other risks associated with, being overweight and being insulin resistant. And there's so many things that my doctors were like, well, if you don't want to do birth control, it's fine. And this doctor was like, no, we need to come up with a treatment plan to help you. And I just find that so rare in the medical field. And I think part of it is because the only physical visual symptom I have is that I'm overweight. So a doctor's response is lose weight, eat healthier, diet, exercise, and not like, let's talk about testosterone levels, or let's talk about, if you want to have children, which I don't. So there's a lot of discussion that like most doctors haven't had, and I finally found a good one. And I cry every time I go to see her, because it's just so special to like have that experience. But I just want to thank you because this talk is really important. And I've not talked about my PCOS until recently because it is kind of a stigmatized shame kind of thing. I think a lot of it is like, it's your reproductive system. I feel like some women are uncomfortable saying like, I have cysts on my ovaries or I have polycystic ovarian syndrome because reproductive systems can be taboo and, you know, not something that people really want to talk about. But I think that you're doing really important work and I just want to say thank you.
Thank you so much. And thank you for sharing your story too. And good point about the lacking menstrual cycle can, you know, over time put one at risk for endometrial cancer, for example. And I know for me, I had that issue of not menstruating for the longest time. And so I would take medicine to bring it on. I think 4 times a year was what the recommendation was so that you could, you know, clear out and not have accumulation inside. But kind of fun fact, I am now very regular with my menstrual cycle, and apparently that can happen as one ages. And so as one reaches older, I'm 45, and so like it's like apparently I'm more fertile now, which is not an issue for me. But yeah, it's very understudied, unknown. Physicians don't know about it, and there are some health risks that are consequential to that invisibility. So thank you all so much for sharing your stories too. So it sounds like folks are in the same boat in the chat. Yeah, so you've had surgery to remove cysts, insulin resistant. Interesting. So those kind of our symptoms, right, of PCOS. And then an OBGYN has said not to worry. Yeah, I would not listen to that person. So whoever said they found someone good in Knoxville, if you are open to sharing that person's name in the chat, I think, you know, we can proceed with sharing the good physicians that are helpful to us. I think that can really, at a grassroots level, move us forward before big changes are made. So please share any good resources in the chat. I also will say PCOS Challenge is that advocacy organization that I've recently in the last year been volunteering with them. And we're trying to start a registry for patients so that people with PCOS can learn about other people with PCOS, and also that researchers can tap into this information and study it more systematically. So, but they have a lot of kind of awareness efforts. September is PCOS Awareness Month. And so like, if you want to get involved with that, I think that would be awesome. Just, I say, share your stories. That's the biggest thing we can do right now. Just let it be known.
We just have a couple of minutes left, and I wanted to, thank you, Hannah. I wanted to say that Teresa had asked in the chat, I think right above where you were looking, Stacey, are female OBs more sensitive about PCOS? Is that something you uncovered in your research?
I have not found any systematic studies of the gender of the physician. In my study, there were comments about how this bias is across the board, the lack of knowledge is across the board. But you know, I hesitate to make any firm kind of definitive comments about who is more knowledgeable or not, since I haven't really seen any systematic studies of that. But that's a great question.
And then I saw both River and Bethany have had hands up at various points in this.
Sorry.
Yeah. No, that's all right.
Yeah, go ahead, River.
Hi, I just wanted to, I guess, thank the part you said about kind of intersectionality and visibility. I think because gender is such a difficult subject for people, I sometimes feel like I can't talk about PCOS because like I don't really know if it is considered intersex or not. I've had people in the intersex community say it is, and I've also had people say it isn't. And I think it can just be conflicting as well. Like, I'm definitely, like, I identify as queer, and I kind of wonder if like having these masculine attributes affects that. But I think sometimes even saying that, people can be very like threatened by saying that because, yeah, of views of like gender in general. So just wanted to say I appreciated the inclusive language you used.
Thank you. And I'm so glad you raised that point, that the intersex question did come up in the interviews by some people. And some people really claim that intersex identity, even if they were born female, kind of assigned at birth. Claiming an intersex identity can be helpful because it explains so much of the PCOS experience. And yet there were others that were like, no, this is not. And actually, I went last year, asked a physician who studies PCOS the same question. And he was like, no, you have ovaries, so you're female. But it's, I still think, up in the air. And is it more helpful for some people to have that identity? Bethany, do we have time to get to you?
Yeah, I mean, I was having issues with my computer earlier and I unmuted and nobody could hear me. So I'm sorry. And I kind of lost my real big question, but I did want to speak to that a little bit. We touch on this in the sex, gender, and the body course, because when you really dive into body studies, you see really how we don't value the diversity in biology. And so, I mean, it sounds like a lot of what your participants spoke to was, you know, if I don't fit neatly into these boxes, there's something wrong with me. And I have to fix myself in these ways that are culturally acceptable in order to, you know, to meet these standards. And even this conversation about intersex identity, and that's a biological function, right? That we all have differences at hormonal levels and our sex organs and all of these things vary, chromosomes, and it's more complicated than just having ovaries, you know? So, I mean, I think as a culture and maybe even more widely, we stigmatize these conversations and feel like they're taboo. And really, I don't know, for me, it really is just about speaking more to the diversity that exists, the expansiveness of how we can show up and how our bodies show up in this world. And the diversity is what makes us so beautiful. So anyway, thank you for your work as always, and for the stories that you shared with us from your research, because I thought that was just really excellent. So thank you.
And thank you, Bethany, for raising that in a really beautiful way, of this expansiveness of gender and of bodies, and just celebrating all of that. You really spoke well about that. So thank you for raising that as our probably final point today. So thanks.
Yeah, we are 2 minutes past 1 p.m. So I want to be respectful of everyone's time. So thank you, Dr. Williams. If everybody want to throw up your invisible silent claps or your clap emoji, whatever works for the device that you're on. We so appreciate this. This recording will be available later via YouTube. If you keep an eye on the WGSS social media somewhere. And then I also wanted to say that our next talk is on October 27th. We'll have Dr. Mickey White discussing navigating queer and trans self-disclosure in higher education. So that should also be wonderful. But again, thank you all for being here. And thank you, Dr. Williams, for sharing your research with us. That was incredible.
Thank you so much, everyone. Thanks.